Alrighty, welcome everyone who has already joined. We'll give just a few more minutes for additional people to join and then we'll get started. Okay, I think we'll go ahead and get started. Welcome everyone to this evening's Equine Seminar Series. Thank you so much for joining us. Tonight's seminar will be on dental care for senior horses. Before we get started, I'll make just a few announcements regarding our upcoming seminars. We hope that you'll be able to join us again next month on Tuesday, April 15th. Dr. Lindsay Goodale will present on the Horse Farm Improvement Program. We're also very excited to announce that our May seminar, which will be on Tuesday, May 20th, will have an in-person attendance option. And this is going to be held at the new facility at the Cornell Equine Park. So keep an eye on your inboxes for further information on the event and how to register. If you can't make it in person, don't worry. We are going to simultaneously have a Zoom option for the May seminar as well. Alrighty, with that, I will introduce this evening's speaker, Dr. Alexa Wright, speaking on dental care for the senior horse. Dr. Wright is currently an assistant clinical professor of dentistry and oral surgery here at Cornell University. She attended Cornell for vet school, and then she completed an equine internship at Rhinebeck Equine in the Hudson Valley. Following this, she spent a year in private practice and then returned to Cornell to complete an equine and small animal dual track dentistry residency program. Dr. Wright's primary area of interest within equine dentistry lies in tooth resorption, and tonight she'll talk to us specifically about dental care for the senior horse. We welcome questions during the seminar. Please use the Q&A tool for your questions. Some we'll answer as we go, and then we'll have time for questions at the end of the talk as well. My pleasure to introduce Dr. Alexa Wright, and she'll go ahead and take over.
Great. Thank you for that introduction, and I'm super excited to be talking to you all tonight. Geriatric dentistry is really near and dear to my heart. I have my own geriatric horses that I care for as well, and I really think that continued dental care is something that can really help their lifelong wellness overall, as well as the health for the individual teeth themselves, which I'll go over. So for this talk, as kind of an overview, I'll first talk to you a little bit about the unique dynamic anatomy that is the horse's teeth. It's very different than our teeth or dog and cat teeth. And their unique anatomy kind of gives them some advantages to kind of put up with certain diseases, but also can lead to some diseases as they get older and as the teeth change in their anatomy. I'll also briefly go over what's involved in an equine oral exam and kind of how to systematically check all the teeth for different common diseases. And then I'll go through some case examples of two diseases that get more and more common as horses get older. The first one is called periodontitis, which is disease of the attachment of the tooth in the socket. And then there's another disease that's very common. It's a very long-winded name. It specifically affects the incisors. It's called equine odontoclastic tooth resorption and hypercementosis. And as Dr. Nickelbein said, that disease is really my primary area of interest for kind of long-term research and trying to figure out more about it. So horses are categorized as hypsodonts, which is a fancy word to describe that they have very long teeth that will erupt over the course of their life. And as they continue to erupt, they will also continue to wear away as the horse is normally tearing and shearing hay and grass and normal forage as part of their normal diet. So they've evolved to have this type of tooth that is very different than our dogs, cats, or ourselves. And so I've given you kind of an overview of what that anatomy looks like. On the left side of the screen, we have their incisors, which are the teeth at the front of their mouth, just when you lift the lips of their muzzle. And the incisors are more simplified in their anatomy in that they have kind of a singular canal in the center of the tooth where the blood supply comes in and keeps the tooth alive. And then the bulk of the tooth, the rest of the tooth, is made up of hard dental tissues, so known as enamel, cementum, and dentin, which allow the teeth to be strong and be able to pick up certain feed or tear grass off the ground, things like that. So that's what they're designed for. And then at the back of the mouth that I have now showed you an image with our scope at the teeth further back, they're called the premolars and molars. And they're usually in a nice neat row of six teeth in a row in all four quadrants of the mouth, so two upper and two lower. And as you can see in the lower image, where there are numbers 1 through 5, and then some extras, 6 and 7 here, they have a more complex anatomy than their incisor counterparts. They have more of a labyrinth of blood supply that make up the center of the tooth here, where the blood supply enters down at the root and then goes up the length of that long crown of the tooth. And then they're still made up of those hard dental tissues that make up the bulk of the tooth. So the cementum, the dentin, and the enamel, and that's what makes them nice and strong. So they can continue to normally chew hay and forage, and that's what makes them also wear away as opposite teeth from the upper and lower jaw wear against each other during normal chewing. And this is important that there is only a certain amount of tooth that's actually present in the mouth itself above the gum line. And then there is a length of tooth that is the reserve crown, the crown that's going to long term eventually become the crown that comes up into the mouth as the horse ages. To kind of give you more of a sense of how that change happens over time, I've included two x-rays, one from a younger horse on the left and the other from an older horse on the right. And where I've outlined in orange is that clinical crown, the crown that's present inside the mouth. It's doing the bulk of the work for the chewing, for them grazing, all day long. And then below the gum line, below that black line that I have on both images and outlined in blue, is the reserve crown that the rest of the tooth that's just kind of waiting to erupt over time and become the clinical crown. And then in purple, I've outlined their roots. So unlike certain species that you might know about, like rabbits, where they continually produce tooth over time and then also grind hay and the occlusal surface will grind away. Horses actually have a finite amount of tooth. So their roots develop when they're about 6 years old. And so these roots are short and still in the process of developing on the left x-ray. And then on the right x-ray, you can see that later on when the horse is older, we have a lot less reserve crown outlined in blue, and we have a lot more root outlined that they're kind of long and tapered and fully developed at this point. So this is an example of a shorter overall amount of tooth that has over time erupted into the mouth and worn away at a normal rate. And the typical rate over a given year is that the tooth will erupt about 2 to 3 millimeters into the mouth, and that a same amount in a normal horse's mouth is going to wear away at the same rate. And so that's how their occlusal surface stays at the correct level for them to continually chew their hay, chew their grass, etc. And to kind of give you a little more visualization of how that changes over time, because I do recognize that x-rays can sometimes be a bit of a mental gymnastic. In the top row, from left to right, I have images of that occlusal surface, that grinding surface of the crown that's in the mouth. And on the in the younger horse, which is on the left side of the screen, we can see 5 really darkly staining pulp horns, which mimic the labyrinth of blood supply on the inside of the tooth there. And then as the horse ages over time, the occlusal surface itself is going to change as we get further and further down the normal anatomy of the tooth. And as you can see here on some of these examples of teeth that we've extracted over the years, the actual length of the tooth changes over time, as well as the shape of roots and how wide versus tapered and narrowed they can be as the horse ages. And just to give you a little more perspective of just how much tooth they really start with when they're younger, when the tooth is done developing, I've included a picture of a horse's tooth that was in a 5-year-old horse that we had to extract next to one of my small animal patients that in the week prior to that extraction, I had to do a number of extractions in her mouth. So the really vast size of these horses' teeth is quite remarkable and makes sense for why they can last for decades of the horse's life as they erupt over time as well. So continuing on their anatomy, there is not only the anatomy of the bulk of the tooth, that blood supply, and then those hard dental tissues that are making up the whole tooth, but there's also the anatomy of what holds the tooth in the socket. And so that's called the periodontal anatomy or the periodontium. And there are 4 components. The first attachment of the tooth is the gum line. So the gingiva that's up in that on that clinical crown that's in the mouth doing the bulk of the chewing work. And then deeper to that gingiva attachment is the periodontal ligament, which is a soft tissue ligament that's going to anchor from the most peripheral layer of the tooth, which is known as cementum, to the alveolar bone, which is the bone that makes up the socket that the tooth sits in. And so these 4 pieces of attachment are super important for that tooth's long-term function because it handles normal wear and tear with all the forces of a normal chewing cycle for the horse, and so is really crucial to those teeth remaining in the correct position they need to be in to be able to effectively tear and shear hay. So when this anatomy gets compromised, then teeth can shift, be in malpositioned, and the chewing cycle can be less effective. And then I've included some images here of kind of when they can get abnormal. And so not only can they maybe tip in one direction, which I'll show you more images of, in a second, but they can also get abnormal spacing between them and food packed into them, which you can pick up on with a scope like we do with our exam or with a dental mirror for their annual oral exam as well. So when thinking about that normal, nice, neat row that I showed you a couple of slides ago of all 6 premolars and molars making up each of the 4 quadrants, they should be nice and tight next to each other. There should be no spacing between one tooth to another. And really, when a abnormal space does develop between those teeth, then unfortunately their hay or other feed can get trapped between the teeth. And this can lead to a lot of inflammation of that attachment of the tooth. So first starting with the gingiva, the gum line, and then if it persists chronically, the inflammation will spread down to that ligament that's holding the tooth in place, and it can also affect the bone of the socket itself. And the way to think about that and how that causes inflammation, if you can imagine having a popcorn kernel stuck between your teeth for months on end, unable to get out, that would be pretty irritating to the tissues that's surrounding it. And that inflammation, if persistent and that nidus is not removed, then you also would experience gingivitis, bleeding of your gums, and attachment loss as well. So it's a similar principle in the horse, but unfortunately develops from also their normal, typical type of feed, like hay, that can really get wedged into abnormal spaces pretty easily. The good news is that because they are hypsodonts and they continually erupt over their lifespan, if you catch these abnormal spacing and feed entrapments early and treat them, then you can stop attachment loss and stop the inflammation. And as the tooth continues to erupt, it'll become kind of at a more normal functional space as well. So overall, kind of what's involved in a general equine oral exam. First and foremost, a physical exam is always super important. So making sure there's nothing abnormal with their heart, lungs, making sure they have a normal temperature before you go ahead and sedate them, because you don't want them to have a poor sedation if something has changed systemically for them. And it's really important that their oral exam be a sedated oral exam, which is why it's just so crucial that your veterinarian be performing these exams annually. A sedated oral exam is really going to allow full kind of targeted assessment of all the teeth in the horse's mouth. And that's going to be really important to picking up on some of the common problems that we find, especially as horses get older. And then once they're sedate, the first part of the exam is the extraoral exam, palpating the outside of their face, making sure there are no new swellings, draining tracts, any asymmetry from side to side externally, and then also lifting the lips and checking out the incisors first, because the would like to see what the incisors look like before placing the speculum, because the speculum is going to put a lot of pressure on those incisors to open the mouth for the intraoral part of the exam. And we want to make sure that there isn't any fractured incisors or other disease like EOTRH, which we'll talk about in a little bit, before placing that speculum and putting all that pressure on those front teeth. And then once the speculum is in place and with a really good headlamp and a mirror or an endoscope, then careful evaluation of each individual cheek tooth, premolars and molars, is necessary to pick up on kind of the common things that we can find. So I've included a couple of examples of the common problems. So the first is any incisor disease, which I'll go into more detail later in this talk. The second is probably something we're all very familiar with which are those sharp enamel points. So sharp points on either the cheek side of the upper cheek teeth or the tongue side of the lower cheek teeth that are kind of cutting into the soft tissues of the cheek or tongue and causing ulcerations. And those sharp points develop secondary to just normal chewing and wearing away of the tooth, and certainly need to be addressed if they're causing ulcers and need to be smoothed slightly so that they don't continue to cause ulcers and pain in the mouth. And then the next really common problem, especially as horses are getting older, are those diastemas. So that's the abnormal spacing between cheek teeth that shouldn't be there, that also potentially is entrapping feed. And then the last one that I've given an example of, which I could give a whole other talk on fractured teeth in horses specifically, but luckily fractured teeth are less common than the other three problems I've listed, but certainly something that it's really important on every annual oral exam for your veterinarian to be evaluating for, to make sure there's not a part of that clinical crown in the mouth that's missing, and to determine kind of how much of the tooth is missing, and is it something that can be monitored or something that's going to lead to a secondary problem and need further investigation and further treatment like extraction. But that is a talk for another time, and we'll focus specifically here on the diastemas next. So periodontal disease is painful. Like I said, if you can imagine that popcorn kernel stuck between your own teeth, imagine if it was for months or over a year before someone was able to get it out for you, that would be pretty inflammatory for your tissues. And how horses usually present is that they could be dropping their feed. So that can either be their hay or their grain, quitting, which is where they're chewing their hay, kind of balling it up and spitting it out. And then there also can be cases of horses that are either having trouble keeping weight on, even though it's during the summer and they're out on pasture all day, to a little bit of weight loss as well, just because their normal chewing cycle and their normal kind of ability to do so comfortably is affected by this disease. And on oral exam, not only are we looking for those abnormal space with packing, I have included an image of a tooth that's kind of shifted out of that nice neat row among the other teeth. And if a tooth is shifted in a certain direction, that's also a sign that potentially that attachment that's usually holding it into its normal socket has been affected, and potentially the tooth is mobile or there are other problems that need to be investigated to see if the tooth unfortunately would need to be extracted at that time. In addition to the abnormal spacing and packing, there are also ways to evaluate the sides of the teeth to see if the gum line itself is receding along the crown as well. Because that recession of the gum line is also secondary to that inflammation too, and can indicate that the pocket might be getting deeper and that the tissues that are deeper to where the food is getting trapped are also inflamed and affected. And then additionally, we're also looking to see if there are any teeth in the mouth that are taller, longer than the other teeth in the row. And why that's really important is that these taller teeth, or the wave mouth that is sometimes called, that some people call, the tall tooth could actually put more pressure on the tooth opposite when it's chewing and grinding, and that could also kind of exacerbate packing food into an abnormal space. So these are kind of all the things that your vet is thinking about, and that we're thinking about when we're evaluating our patients of what could be kind of contributing to this chronic food entrapment and chronic abnormal spacing between teeth. And just to kind of highlight really how common this disease is, I included this paper even though it's a bit older, in 2008 and 2009. This is a condition that we've certainly been aware of and treating in horses for a long time now. But they looked at 471 horses across the UK, and they found that up to 50% of the population had at least one diastema, if not multiple diastemas. Majority of their cases were in the lower cheek teeth on the mandible, but there was a percentage of them that also were affecting the upper cheek teeth. And what was really important in this paper as well is that with the increasing age group, there was a higher likelihood of a diastema being present, be it one or multiple diastema. And kind of the cutoff where they saw that trend happen was around 15 years old. So horses that are 15 years and older have a much higher likelihood of having this problem. And our horses are living well into their 20s now. And so it's very crucial to kind of get on the normal habit of an annual oral exam to try to catch these diastemas earlier before they cause inflammation that goes into the deeper tissues around the tooth. In addition, to kind of add a complication to our horses living longer and longer, as we get further and further down the reserve crown as it erupts into the mouth, you can see here that the crown actually tapers where the reserve crown meets the roots. And you can see it on both of these teeth here at different ages even too. And so when this part of the tooth erupts into the mouth, that means a smaller amount of tooth is occupying the same space as the robust younger version of its clinical crown and occlusal surface did in the mouth earlier in its life. And that's just going to naturally cause spacing between these cheek teeth that wasn't there prior. And so these are called senile diastemas. They're not something that we can prevent, unfortunately, but they are something that do need attention and further treatment, and something to think about as horses are getting up into their mid to late 20s, because they are even more likely, due to their age, to have these abnormal spacing where feed can get trapped and cause problems. So here I've included some images of senile diastemas that after flushing, you can see, even without me having to physically kind of pick the hay out of the space, there is some inflammation and bleeding of the gum line here. And then here in this image, you can see that the gum line has actually receded along the root of this tooth and the root of that tooth as well. So we should not be able to see these root structures in a normal situation, and the food packing in that area kind of exacerbated that tissue attachment loss. And now we can see the roots, even though that part of the tooth hasn't erupted into the mouth yet. So during the oral exam, it's really important to identify what stage of periodontal disease the horse is in. And what that really comes down to is how much attachment loss has happened. So, and how much in a percent from where the periodontal ligament should really anchor to the bone up by the clinical crown, which is outlined by the white line on the X-ray image in the bottom right. Um, from there to the tip of the root is there bone attachment that we can see on x-ray. And so we're looking at kind of this bone that's between these cheek teeth. And this is an example of a normal horse where we have nice kind of white bone that you can see between each of these teeth here, coming right up to where the clinical crown has erupted into the mouth. So any loss below this line, any lack of bone below this line is going to be categorized in a certain percent of bone loss. And once we get over 50% bone loss, that's where we start to see teeth becoming mobile, pockets getting deeper, and food trapping deeper. And it's no longer a situation that we can kind of conservatively manage and help by just removing the food for them. It may be something that needs extraction sooner rather than later. There are two types of diastemas to think about that we're looking for as vets. There is the open diastema, which you can see on the left side of the screen, which is just a clear space between the teeth. And then there's the valve diastema on the right side of the screen, where the occlusal surface of the teeth is still touching, but there is an abnormal space between the teeth towards the gum line. And as you can probably see, the valve diastema, it has a much easier time of trapping food to stay there and not move along with normal flow of saliva and normal chewing. Whereas the open diastemas, as long as the tissues aren't inflamed, the pockets aren't very deep, it is possible with normal chewing and normal salivary flow for the food to not get as trapped and not be as big a problem. So differentiating these types is also important for treatment planning. And where treatment, what treatment options we have were kind of nicely outlined in this paper that I've included as well, where the conservative basic form of treatment is just removing that food and lavaging the space and really getting that foreign material out of there that's causing the inflammation. Then there are higher tiers that vets have done with either after removing the food, packing metronidazole in there or packing some synthetic material in there to try to prevent food from going in there in between cleaning. And then doing something called diastema widening, which comes with its own complications and is not is beyond the scope of this talk today. But what's really interesting from this paper is the outcome that the conservative management of just removing the food and lavaging did just as well as the higher tier options. And so really that means that the crux of the treatment that was effective was removing that food and, for lack of a better term, flossing for them and getting it out of there for them. And so that option, that conservative management, should really always be considered and performed before we jump to something like extraction. So I'll go over a couple of cases. So this first one is a 19-year-old Welsh pony gelding who had presented for oral exam because he was dropping feed. He was balling up his hay, spitting it out. And as you can see on the scope image on the left, there is a lot of food that's around this last molar on his left lower jaw. And it's wedging between this molar and the molar in front of it. And after just a little bit of water lavage to try to get a better look, you can also see that the feed is really stuck in there. It's very wedged in there. So in order to remove it, I needed to use certain instruments to kind of pick it out and floss for him. And then what's recommended next after assessing how deep that pocket is, how far the food was packing into the gingiva, are some x-rays to see what our bone attachment is doing. So on this x-ray, I'll show you. Here is the last molar in question that we were looking at on our exam. And the bone attachment should come right up here to where the clinical crown is erupting into the mouth. And where I have the arrow for you is actually where that bright white bone is attaching. And here we have more darker gray, which means there's been bone loss. And so looking at this from where it should be attached down to the tip of the root, we're still at the less than 50% mark. So what we can do is continue to clean the feed out periodically and take repeat x-rays in the future in order to see if that attachment loss progressive, that if that inflammation progresses, or does our conservative management of cleaning out the feed do enough to kind of maintain normal attachment and maintain functionality for this tooth. So we were able to see him about a month later. He was being sedated for another reason. So we went ahead and did a quick oral exam just to see after our cleaning how we did. And so just after removing that feed that I really had to pick to get out, on this exam a month later, you can see that the gingiva is nice and healthy pink. None of it is ulcerated or bleeding. This is even before really lavaging it with a lot of water. So the feed in this open diastema has been able to kind of move along with normal mastication and normal salivary flow, and that inflammation has calmed down. So even with just a month of having removed that wedge feed, we've really calmed down the inflammation and calmed down his oral pain in the process as well. In this next example, we have a 24-year-old quarter horse mare who presented for a bit of weight loss, mainly that it had been all summer long. She had been on pasture this whole time, but she's really not being the easy keeper that she used to be. And her weight loss hasn't been super drastic, but it's certainly been noticeable to the owner. And so on oral exam, we found multiple diastemas, both affecting her upper left cheek teeth, as well as abnormal spaces, but not necessarily with food entrapment on her lower cheek teeth as well. So we went ahead and did some x-rays to further assess what the bone attachment is looking like. And all things considered, there's some bone attachment where it should be all the way up to here, but the white bone has come down to here, but we can still monitor this long term. But there's been a decent amount of bone loss on the upper left molar, that's number 209. So with these findings kind of combined, it helps us make a treatment plan of what teeth can be monitored and what teeth need to be prioritized for treatment. And so in this case, this molar, the 209, was mobile once we cleaned that food out. So all of those signs combined, extraction of that tooth is recommended, whereas monitoring of the other teeth can be done at this stage. And then the last example I have for this disease is a 24-year-old warm blood gelding who presented just for an annual oral exam with us. And we did find a diastema between his lower right teeth, numbers 408 and 409, with some food entrapment here. And so after we cleaned this out, we found that the pocket wasn't too deep, but everything was still inflamed. So we did recommend some x-rays. And I'll show you here, this is 409 and this is 408, and we're looking at the bone attachment between these two teeth. And so there's really a minimal amount. And truly that space that's abnormal, that trapped food, is pretty narrow right now. So we recommended that he come back in a year for us to reassess, clean the diastema again if it's still there, and take some repeat x-rays. And so he did come back in a year. And we did have kind of a similar appearance to the diastema, similar amount of food entrapment, similar amount of inflammation. And here on his x-ray, while the diastema has still remained pretty narrow, there does seem to be a bit more loss, which I know is maybe hard to see when you're not looking at these x-rays, but instead of the bone being up to here, like it was in 2023, now it's kind of come down the neck of the tooth closer to the root structure here. And so we recommended at that point for him to come back sooner, because the more frequently that you're able to clean out the diastemas and tamper down the inflammation, the more likely you're able to stop the bone attachment kind of in its tracks. So he did come back for a 6-month recheck. And what we found on our x-rays here is that the bone loss had kind of stayed the same. It had kind of tapered off right at the level of where the crown is meeting that root structure as it was in April before. So now we recommended every 6 months he continue to come to kind of keep it at that level of attachment and monitoring and management. And then, sorry, this is actually the last one for the disease, kind of the most severe form. In this 20-year-old warm blood mare, there was a pretty wide diastema with food that was really packing deep between the 408 and 409 tooth. And here is just an example of an x-ray that the bone has actually been lost all along the whole length of the tooth here, to the point that it's actually circled around the root here. So this is meeting the mark for that greater than 50% bone loss. And this tooth at this point can't be conservatively managed or saved. It needed to be extracted at that time. So now I'll go on to the second disease for the night, which is another really common disease on aging horses. It's called EOTRH. It is a painful and progressive disease involving loss of those dental hard tissues, so that cementum, enamel, dentin that make up the bulk of the tooth itself, as well as the periodontium, the tissues that are holding the tooth in the socket. And that chronic loss of the hard dental tissues and that inflammation is what's really causing pain to the horse, because as those tissues get kind of munched away, we get closer and closer to the central blood supply of the tooth. And that's really where pain signals can be sent to the rest of the body as well when that area gets compromised. So, in addition to kind of loss of attachment and the discomfort that can come from that, it also has this added inflammatory component that causes pain of the incisors. It's very common among the general horse population. We don't know what causes it. More research is really needed to better understand the disease. But what we do know is that it is more common as horses age. So horses that are 15 and up are more likely to have this disease. It has been reported in horses as young as 11 or 12, but certainly the horses that are into their 20s, this should be a disease that's on everyone's radar. There also was a recent study that showed that it's more common, or there's a higher predilection for it in geldings than mares, but we need more information to know the significance of that as well. It typically affects the incisors and canine teeth, but it has also been reported to affect the cheek teeth. So there are some severe forms that are actually affecting all the teeth in the horse's mouth. And then the only intervention we have at this time, because we really don't know what causes it, is extraction of those affected incisors and canine teeth to relieve the pain, which is pretty invasive, but can do a lot of good for the horse for their level of comfort long term. So the typical presentation are the same signs of oral pain that we're thinking about for periodontal disease. So dropping feed, potentially a little bit of weight loss. They can have other abnormal chewing behaviors, but something that you all will likely pick up on a lot is when you're placing the bit in your older horse's mouth, if they become a lot more bit sensitive in that process, because if the bit hits up against those incisors that are already kind of chronically inflamed and painful, then that's going to exacerbate the pain kind of acutely in that moment. And then one of the ways that we often find it as vets is that it's an incidental finding on our annual oral exam. So perhaps it's a horse that we've done exams on for many years, starting when they were like 8 and they were totally fine for sedation and the speculum use, et cetera. And then now they're 18 years old. And on this exam, we needed more sedation to get it done, or they really didn't tolerate the use of the speculum, putting all that pressure on the incisors to open their mouth. So at that point, it should set off a light bulb to kind of look into whether or not they have this disease. And the main way to really diagnose it is with X-rays. Before you place the speculum, it's really important that part of that oral exam is looking at those incisors. And here I've included an image from a paper written by Dr. Early, who's the other dentist at Cornell. And there are certain cases that will have kind of bulging of their gum line. They can have little areas of inflammation and draining tracts. Even further along their gums, it can be look like there's actually more tooth underneath the surface and then it's bulging up. And these can be kind of signs that you can pick up on in later disease before speculum use, but certainly they can look grossly normal before you place the speculum on, and then if they're still painful with that speculum use, you still should probably investigate for this disease. So X-rays, like I said, are critical to be able to see what's going on below the gum line and to tell if there is any changes that would indicate the horse has this disease. So this example from this horse has the different parts of the disease. So the T and the R stand for tooth resorption. So that's where we have kind of cookie monster bites out of the side of a given tooth, where it should be kind of a nice straight line here, similar to, I guess, this one is more normal. But here we've kind of resorbed away those hard dental tissues that make up the bulk of the tooth, um, as well as the tooth is, I can tell you, is a little shorter than it should be. So there's also been resorption and loss along the length of the tooth as well. And then the H stands for hypercementosis. So, like I said, the cementum is that outer layer of the tooth where the periodontal ligament is anchoring into the socket. And part of this disease is laying down excess cementum for unknown reason. It could potentially be a coping mechanism of the tooth. It's losing its attachment, it's trying to hang on. So it lays down extra cementum secondarily. But again, more information is needed to kind of further understand the mechanism of the disease, let alone the cause as well. And then, like I said, it can affect cheek teeth. So here is an example of a case that was published where the incisors themselves weren't super abnormal. There wasn't a lot of excess cementum. There are some areas where it's bulging out here that I can highlight for you. But overall, these incisors look pretty typical and normal radiographically. But then on the x-rays of their cheek teeth, what we're seeing is kind of really bulbous, thicker roots than those nice long tapered ones that I showed you in earlier x-rays. And so that's a sign of the hypercementosis going on as well. And they confirmed after extracting some of these teeth histologically, with our lab, or a lab, that they did have EOTRH affecting these specific teeth as well. And these cases can be very tricky because, like I said, extraction is the mainstay of treatment right now of the affected teeth, but a horse can't survive with all of the cheek teeth extracted from them. So that's really not an option either. So in these kind of more severe cases where all of the teeth are affected, it's looking a little bit more like chronic pain management, but that's not ideal because they're still going to have chronic pain from this disease being progressive. So we can go through a couple of case examples to kind of highlight how they can present and what they look like and how they do after incisor extractions for the more common presentation of this disease only affecting the incisors and canine teeth. These are x-rays from a 17-year-old pink gelding who progressively had more sensitivity to speculum use on his annual oral exams. And as you can see on these x-rays, there are areas where we have that extra cementum kind of being laid down in a bulbous fashion. And then we also have these areas of kind of, for lack of a better term, cookie monster bites out of the side of the tooth, where it should be this nice bright white along the whole length of the tooth, but we have areas that have a little bit of black. And so you can see here that this area shows that that hard dental tissue has been eaten away for unknown reason from inflammation. And so he did go for full incisor and canine extractions. And this is him about 4 weeks after the extractions. The sites are healing in really nicely. They're nearly there. And he's already a lot less head shy when the owners are palpating or feeling around his lips and lifting his lips for photos for monitoring. So he's already feeling a lot better just 4 weeks after surgery. And what I typically tell owners after this surgery is that their tongue will stick out a tiny bit, but it's often pretty cute. And they do functionally super well. They can go back into work, they can go back into riding with a bit if they need to. They also do a very good job with their normal diet longer term. So it's not like they can't graze ever again because they don't have their incisors anymore. They very well can. They actually do a lot of the tearing of grass with their lips. Their lips are just so strong that they can eat their normal diet once they're healed and really maintain a really nice overall body weight. And they're just going to be more comfortable. They're not going to have bit sensitivity anymore. They're not going to have the chronic inflammation and pain from those teeth kind of being eaten away. And they are also going to tolerate, you you feeling around their mouth and being less head shy in general. So the next case is a 21-year-old warm blood gelding who was presented because he had a fractured incisor as well as a couple missing incisors. And they wanted to look further into why that was. So fractured incisors can actually be secondary to that loss of the hard dental tissue. So if it gets munched away enough, it can actually weaken it to a point that it'll fracture just in the normal day-to-day life for that horse. And so in addition to this fractured incisor here where we're missing the crown like its neighboring teeth, we also have some of the signs that I pointed out before. We have bulging below the gum line, as well as on x-ray, we have resorption. These teeth are actually super short from what they should be in length. There are areas that have kind of moth-eaten appearance to it, which is that tooth resorption going on in both the canine teeth as well as the incisors here that I'm pointing out. So it was recommended to do full incisor and canine extractions for him as well. And apologies for a little bit of a bloody photo, but we do try here to do our extraction surgically so that we can actually close the gum line with suture so that way they can heal a bit faster. They also can heal by second intention. So this can be done both ways, where the sockets are left open to heal on their own kind of in a longer time frame, or they can be closed like this and heal primarily. And I was lucky enough to kind of follow this horse, and these follow-up images were provided by his caretaker because he's actually at the same retirement farm as my own horses. So I have a video of him here that should play that, no, hopefully. Oh, we tested it. Let me go back. There it goes. Where after he's fully healed, this is actually him with my gelding. They're grooming each other. He's using his incisor area just normally. He's able to graze super well. He keeps a really nice body condition. And then I'll just play it one more time for you because my other geriatric horse, my pony mare, is a little jealous of him getting more attention. But overall, he did super well. And he was a really large warm blood cross. So he kept his body weight very excellently for years after the extractions. And so I really can't speak highly enough of this intervention, as invasive as it may seem, because it can really make them comfortable long term in their older age. And then there are cases that we kind of monitor before we jump to that invasive extraction of all of their incisors and canine teeth. So this is an example of a 22-year-old warm blood gelding that on initial exams that we had seen him over the years, he wasn't sensitive to speculum use. And then when he turned 22 and we saw him that year, he did have a bit of sensitivity where we put all that pressure on those incisors to open the mouth. He was chewing more during the exam. He needed more sedation than he had in previous years. So we went ahead and recommended getting some x-rays. He did also have some signs of bulging below the gum line, but it hadn't really changed over the years that we had seen him for exam. But we do have kind of serial x-rays on him, which can show you kind of that change in how the disease is progressive with time. And so these were the initial survey x-rays that we took in one of his earlier exams, just because of how his incisors looked generally. And we can see a little bit of extra cementum laying down here. Perhaps these roots are shorter than the length that they should be in these central incisors. But overall, because he didn't have pain when using the speculum and opening his mouth, we didn't really need to recommend any invasive treatments at that time. But then in 2024, when he did have that sensitivity, we went ahead and repeated x-rays. And you can see here that these teeth are even shorter now. We have more bulging and extra cementum laying down on the outside of the teeth. We have areas that are a bit more moth-eaten and showing signs of tooth resorption. And so at this point, We discussed with the owner that extraction of these incisors may be necessary within the coming year. And it can be kind of chronically managed with a daily nonsteroidal like Equiox or Bute, but daily nonsteroidals come with other potential side effects and certainly are not going to tackle all of the pain, all of the chronic pain that these teeth are causing all day. So right now, our best option is extracting these teeth and getting him comfortable once he heals. So, in summary of these two diseases, the dynamic anatomy of horse teeth, and as they continue to erupt, allows them to cope with a lot of things that they're dealing with. And if we catch these diseases earlier, it is possible to get them into kind of a more normal anatomy and chewing surface in their mouth. But changes related to age can also result in painful periodontitis where there are abnormal spaces in feed entrapment. And diseases like periodontitis and EOTRH are unfortunately just more common as horses age, which is why it's just so important to continue annual oral exams with your veterinarian and look out for these things that may need further intervention like extraction in the future to keep them comfortable long term as they get older and older. And those regular oral exams can also be paired with dental x-rays. The dental x-rays are really crucial to kind of evaluating what's going on below the gum line. You know, think of the crown of the tooth as the tip of the iceberg, and that we need to know more going on for both periodontal disease as well as EOTRH. And that, you know, if we catch them early enough for periodontitis, the treatment can be conservative, managed on farm very easily, keep them comfy by flossing for them and getting that food out of there. But if we do diagnose EOTRH, the treatment at this time is going to be extraction, but knowing that they can get really great long-term oral comfort and function after that. And that's all I have. I can take any questions.
Awesome. Thank you so much, Dr. Wright, for an excellent talk. We do have a few questions. We'll start with, what do you think are the most common causes for crown fractures in horses?
That's a great question. And again, I could give a whole separate talk on tooth fractures in horses entirely. But right now, for a lot of them, they are idiopathic. So for lack of a better term, we don't know what causes them. It's not necessarily, you know, abnormal height of opposite tooth causing more pressure. It's not necessarily something in their environment that we can pinpoint. But unfortunately, crown fractures are certainly something that we find often as dentists, but are something that veterinarians and general practitioners pick up on in horses as well. There are certain teeth that are more likely to fracture than other teeth, specifically the molars. But again, we don't know why. Is that because of how much force they generate at the back of their mouth versus at the front of their mouth, or something else having to do with their normal chewing cycle? More research is needed for that too.
Excellent. Is there anything that the average horse owner can do to help keep their horse's teeth healthy in between their annual dental exams?
Yeah, this is a good question too, because you know, part of our normal recommendations for our small animal patients is home dental care and toothbrushing, just like how we maintain our teeth in between our dentist visits. Unfortunately for horses, there really isn't a good way to remove the food that's trapped between teeth at the back of the mouth without sedation and a speculum and access to those teeth way back there. So I wish there was a good way for continual flossing at home when the horse is awake, et cetera, but we just can't access safely those parts of their mouths without sedation. So really keeping on top of the annual oral exams or even more frequent oral exams, like every 6 months or something, depending on what your horse has, is what we have right now.
Great. A question regarding EOTRH. Are radiographs of all teeth recommended for this disease or just of the incisors?
Yeah, that's a good question. For us, we at the first kind of evaluation, we always X-ray both the incisors and the cheek teeth to make sure we're not missing a case where the disease is also affecting the cheek teeth. Like I said, extraction is our intervention right now, but we cannot do kind of all cheek teeth extraction on a horse where the disease happens to affect all the teeth. Um, so we want to make sure that we pick up on that before we go ahead and do something like extractions of incisors. And the reason that's important is when the horse is at rest, the incisors are taking most of the just resting force when the horse's mouth is closed. And when you remove those incisors, now all of that force is on the cheek teeth at the back of the mouth, where normally they have a little bit of space between them just at rest when they're not chewing. And so if those teeth are diseased and suddenly they're putting more pressure on each other because you remove the incisors, the horse can actually get more painful after the procedure. So we always rule that out before we go forward with the incisor extractions. And it's good to do just for kind of general assessment as well. You can find problems with cheek teeth that you wouldn't have found if you didn't have x-rays, because again, it's looking at what's happening below the tip of the iceberg.
Great. A lot of questions about EOTRH. So, what approaches to ongoing care are needed for older horses if their teeth do end up being extracted? For example, like what kinds of food should they be fed?
Yeah. So during the healing period, we just ask that they don't graze during that time and put pressure on the area. But after they're fully healed, they can go back out to normal pasture. They can eat hay throughout the whole time as well, just avoiding a hay net while they're actually healing. But once they're healed, they can go back to using a hay net. And then their normal grain that they're typically on. One of the things that I should actually say about what owners can do in between oral exams is any feed changes that might help with the periodontal disease, which can come hand in hand with EOTRH. The horse can have both, and so longer term, they might just need to eat a softer cutting hay, second cut hay, something that's less stiff and starch and able to wedge in between the teeth more easily. And so kind of using that as the feed longer term. And then for kind of long-term care after they've healed from the incisor extractions, they should still get regular dental care for their cheek teeth as well. So even though they don't have their incisors, you are able to use a speculum for oral exams just as long as it's padded with something soft like yoga mat or other padding, so that it doesn't ulcerate the soft tissue around the bone that's still there, but it can still successfully open the mouth and you can get a good oral exam. And if they have a diastema, it can be cleaned even after they don't have their incisors anymore.
Great. Another question about supplements for EOTRH, specifically about a supplement called Equident Mushroom Matrix. Have you heard of this, and do you think it helps with the disease?
Yeah, I've been asked this question before, and one of the thought processes to that supplement is that it's anti-inflammatory in nature, and it's utilized for some other inflammatory diseases as well. In terms of what we know right now about this disease, I would say I would prefer to lean on a medication that's better for pain than the supplement, just because it's not treating the root cause of the progression of the disease. Even though you have them on pain meds or have them on a supplement, the actual process of the tooth being eaten away over time for unknown reason is going to continue. And since that's really the source of the chronic pain, the supplement's not going to change the course of the disease. So unfortunately, that's why we only really have a good option of extracting the affected incisors so that that continued eating away of the tooth is stopped.
Got it. That makes sense. Um, you guys are asking great questions tonight. Another one, realizing that age is not a disease, is it reasonable for a 33-year-old horse with PPID and EOTRH to undergo extractions?
Yeah, that's a really good question too. So we definitely make our recommendation tailored to each individual horse. So it's going to be a combination of their systemic health. So if they have PPID, If it's controlled, perhaps they're a better candidate to undergo surgery and have a good healing time afterward. But if they're not well controlled, they're going to be immunocompromised and have other problems with healing. So that's a decision maker on whether or not it's a procedure they should go through. And then in addition, just kind of because PPID was brought up, horses with PPID can actually have, especially if they're uncontrolled, can actually have really severe periodontal disease. Just their tissues are not the same, doesn't have the same robust defense and normal immune system to stand up to the inflammation from the food entrapment. And so they can actually present with really, really bad deep diastemas that can lead to fistulas or sinus disease or other things too. So a whole nother reason, because PPID is also more common as horses age, to really stay on top of their oral exams, because you definitely want to catch their periodontal disease sooner if they are a PPID horse, more so than a normal horse. Um, but certainly there are PPID horses that we have done EOTRH extractions on. As long as they stay controlled and continue their percent through healing, they can heal really well and do really well long term.
Excellent. You answered part of another question that was raised already about are PPID horses predisposed to dental problems? This question also included, are horses with insulin resistance predisposed to dental problems?
Um, it's possible. Again, there needs to be more research. There has been research in both metabolic syndrome as well as PPID in relation to the health of gingiva and other tissues. But right now, there's not a clear cause and effect. So it's not that one disease is going to predispose them to another. It's just that the disease is more common as horses age for PPID and periodontitis. And then for insulin resistance, there's not been a direct link at all specifically.
Excellent. We have just a couple more questions, which we can probably get through quickly if that sounds okay. A couple on diastemas. So, how often after they are diagnosed do you recommend routinely cleaning the diastema? And then also, what material are you using to pack the diastema?
So for us, I'll answer the second part first. We're not packing with anything. So we truly just follow the conservative management approach at the beginning. The reason we don't pack with anything is one, it's hard to say how long the packing stays there with normal chewing cycle, et cetera. And two, if you pack something solid in the space, you're actually making that space stay the same size as it is currently. Whereas hopefully if you've caught it early enough after you've removed the feed, that space can actually change as the tooth erupts and normal chewing and grinding of the teeth happen. So we don't pack with anything with the horses that come through Cornell. We just floss for them. Um, but for the frequency of how often we clean the diastemas, that's kind of tailored to each individual horse as well. So it depends how deep the diastema is, how inflamed it is, whether or not there's bone loss associated on the x-rays. But say it's not that deep and it's only a little bit inflamed and there really isn't bone loss on the x-ray, you can do it a year from now again at the next annual oral exam. But if there is more attachment loss, more inflammation of the gum line, loss of bone, then I would recommend anywhere from 3 to 4 months to 6 months, depending on how much bone loss is already present, to try to keep ahead of the inflammation and keep up with the food entrapment.
Great. Thank you for that. We will wrap up with one final question here. Do you typically note any reaction to the speculum on your dental exam, and would you recommend that veterinarians do that when they perform their dental exams?
Yeah, so the sensitivity to speculum use is really a good marker for that incisor disease, EOTRH. So it's certainly something to think about and maybe not push the horse with more sedation to try to get through the exam. If they're really reacting to having their mouth opened, maybe stopping, taking off the speculum and taking those incisor x-rays is the better next step to try to assess their overall oral health.
Great. On that note, can you distinguish incisor pain from the speculum from kind of pain of just opening the mouth, like TMJ generated pain or something like that? How do you tease those out on your exam?
Sure. So I will say that TMJ abnormalities in horses are extremely rare. They have been reported to be somewhere around maybe 2% of the horse population, whereas EOTRH is super common, especially in the older horse population. So common things being common, we should first rule out the incisor disease with pain on the speculum use, which is very easy to rule out with some simple x-rays. If you have ruled it out, then you can start thinking about something that's more rare, like TMJ disease. Um, but there have been studies. There's one recently that looked at over 1,000 horses that had head CTs, and very few of them had abnormalities on the CT scans of the TMJ. So it's just luckily not that common, even though it can be harder to diagnose.
Great. Thank you for that. Okay, in the interest of time, we will wrap up here. Thank you all very much for attending, and thank you so much to Dr. Wright for an excellent presentation. We hope to see you all at our next seminar again on Tuesday, April 15th, and then hopefully in person on Tuesday, May 20th. All right, thank you and have a good night.